Good afternoon, everybody. Thank you so much for joining us, and welcome to this event titled Building a Bright Start for New York's Children, a panel on the social, emotional, and developmental needs of young children and their families. This panel is co-hosted by Citizens Committee for Children and the Healthy Minds, Healthy Kids campaign. My name is Alice Buffkin, and I'm the Director of Policy for Child and Adolescent Health at CCC. For those of you unfamiliar with CCC, we are a nonpartisan, multi-issue children's advocacy organization. Our advocacy combines public policy research and data analysis with civic action. We seek to cast light on key issues, educate the public, engage partners, and identify and promote solutions to ensure that every New York child is healthy, housed, educated, and safe. One of the coalitions we help lead is the Healthy Minds, Healthy Kids campaign, a statewide coalition of behavioral health providers, advocates, and New York families joining together to create the public and political will necessary to ensure that all children and adolescents in New York receive the high-quality behavioral health services they need. We're so excited to have you join us for this event, which is focused on discussing innovative opportunities to support the healthy development and social and emotional well-being of infants and toddlers in New York. So to start off the event, we'll be hearing from Bijan Kimiagar, who is CCC's Associate Executive Director for Research. Bijan will be discussing data CCC has been collecting and analyzing on young child development and school readiness. This data is intended to inform community-level programming, as well as citywide and statewide advocacy to support families with young children. We'll then hear from our incredible panel of experts on key issues facing young children and their families and innovative interventions that engage families in strengths-based approaches to young children's growth and development. If you have any questions during the presentation, please put them in the chat box. If we don't have time to address these questions during today's event, we'll do our best to follow up with responses to your questions when we share the recording for this presentation. So without further delay, I'll turn it over to my colleague, Bijan.
Thank you, Alice. I hope everyone can hear me. And I'm going to share some slides that I've prepared for today. Thanks for having me. It's a really big pleasure to be part of this event and this panel today. Over the next 15 minutes, as Alice mentioned, I'll be giving a preview of findings from an analysis of publicly available data that aims to inform community-level programming, as well as citywide and statewide advocacy to support families with young children. I will share a brief background on this work and sources of data. I'll summarize some key citywide findings. I'll spotlight findings for 5 community districts that provide more contextual understanding of the data at large. And finally, I'll share thoughts on how we might use this information moving forward as we advocate for more robust data to inform programming and policies that are responsive to the needs of families with young children. Supporting families with young children is a core component of CCC's advocacy and policy-focused research, and it was through our partners working in the young child space who came to us with questions about measuring young child development that spurred us to dive further. One setting where this discussion has been most vibrant has been in CCC's Learning Collaborative, a group of place-based initiatives throughout New York City, each working in partnership with community organizations and families to improve outcomes for families and increase access to important community resources, including those specifically ensuring young children are healthy and ready to start kindergarten, what we can call school readiness. So the goal of this project is to highlight trends in data relevant to young child development and school readiness for specific communities that would inform their local programs and community change projects, and to summarize where in the city we should be investing in supports for families with young children in ways that could drive policy and budget advocacy. A concept that's central to this analysis and to the advocacy it informs is the idea that child development must be understood as existing within multiple settings. So when we talk about a child being ready to start kindergarten, we must also talk about how their family is also ready to support their child to start school, whether the school system is ready to meet the child's needs and when they enter the classroom or the Zoom room, and whether community conditions where children live also support their healthy development and readiness to learn each day. So while it's important to ensure individual children are ready to start school, this demands putting in place a robust infrastructure of supports across multiple settings. On the screen is a list of indicators currently in the index. There are absolutely many more indicators we could and have considered for this analysis, such as whether children are up to date on pediatric well visits and vaccinations, or enrollment in early intervention, This list of indicators was included in this index because they capture aspects of young child development and school readiness across settings in children's lives, and they meet criteria for being publicly available, that they're reported annually, that they're available at the community district level, and they're reliable, meaning any estimated data have relatively small margins of error. I'll start from the bottom of the list and work my way up. We have several indicators from the Department of Health vital statistics, the share of babies born preterm, share of babies with low birth weight, infant mortality rate, and share of mothers receiving late or no prenatal care. We also have several data points capturing access to and quality of the early education programs, share of families who can afford childcare, share of 3 and 4-year-olds in ECE programs, the pre-K learning environment quality measured by ECHR scores, and separately, we have information on the share of students with a disability, or otherwise known as an individualized education program. While this captures students from across grades, we know that most IEP referrals are in kindergarten. About 1 in 5 are made in kindergarten, and by 3rd grade, 60% of IEP referrals have occurred. We also look at the share of children under 5 in or near poverty, which is below 200% of the federal poverty level, and the share of individuals with limited English proficiency, considering that literacy in English is important in schooling, and thinking about the family supports that whether they have English proficiency to support their children in their learning is also important. And then because the population of children under 5 changes by community district, I argue that where there are more children, there's a greater need to pay attention to how we can support families with young children. During my presentation today, I'll be brief on the methodology, in part because the details about each indicator in the index are available at data.cccnewyork.org. In terms of methods to create the composite index, I standardize data using each indicator using a z-score. Z-scores allow for identifying meaningful variation from the average, so we can tell how much higher or how much lower a statistic is from the average. I use the z-scores for indicators to create a composite index, and it was this composite index that I used to rank all 59 community districts, where the community ranked first has the greatest need for investments to support families with young children. So on to some citywide findings. On the left of the screen is a map of the results of the community level averages. The community districts in yellow are where outcomes are similar to the citywide average. The 9 districts in blue are where there is lower than average need, which this means that outcomes are more favorable for families with young children. These include areas of Lower Manhattan, Williamsburg, Park Slope, Bay Ridge, and Brooklyn, and Regal Park in Queens. Community districts in orange are where there is higher than average need. And these are listed on the table on the right. A complete list of results for the index and the table of indicators is available as a download, which you can use this page to click on and receive that PDF. These slides will be available after today's event. Now, if we compare the results of the Young Child Composite Index to the results of CCC's Child and Family Wellbeing Index, which has a much wider range of topics and indicators, we find that the top 12 ranked community districts in the Young Child Development Index are the same top 12 ranked in the recent Child and Family Wellbeing Index. The key takeaway of this comparison is not to see if a district moves up or down in rank based on indicators. Instead, it's to show that even when we take another point of view of understanding of child and family well-being and restrict this view to the young child space, we find the same results. This means there are other factors that underpin the outcomes we are measuring. We discussed this in our Child and Family Wellbeing Index. And here's some information from that, where in that report, we showed that the child population in communities where there are greater barriers to well-being were almost exclusively Hispanic, Latino, and/or Black, and children living in community districts where there were the fewest barriers to well-being were majority white. This pattern is evidence of persistent and systemic racism and discrimination, and not inherent differences between racial and ethnic groups. And as we go through the findings throughout the index for specific communities, I've included the racial and ethnic breakdown of those communities so that you can see a comparison between that and the outcomes. So in terms of community district spotlights, I'll be spotlighting 5, one from each borough. And I'll take a moment just to explain what's on the screen. In addition to the name and the rank in the top corner, the chart shows the z-score distribution, where those that are towards the top, and especially those in the green, are above the average of average community district in the city, and those at the bottom of the axis are meaningfully below the average. Top or above or below doesn't necessarily mean positive or negative. It depends on each individual indicator. So something like an Ecker score, you want to be higher, but in Morrisania, it's actually lower. It has one of the lowest ones in the city. And that, in addition to the population under 5 in or near poverty, 78% of children under 5 in or near poverty, plus the high share of students with an IEP is what's driving its rank to being the first out of 59 in terms of where there's the greatest need to invest in families with young children. And as I said, explaining the slide, on the right-hand slide, there's a map of the city with a specific community district and the child, racial, and ethnic composition. Another example from Brooklyn, which is ranked, is Brownsville, which is ranked 4. In Brownsville, what's driving the ranking of being 4th is infant and maternal health outcomes. High rate of late or no prenatal care, a high rate of preterm births. These examples we know from other data, citywide data, that we are able to disaggregate by race and ethnicity, that there is persistent racism and discrimination that is explaining these disparate outcomes, and is something that we need to be paying attention to in this particular area, considering that 68% of children in the area are Black or African American. Washington Heights is an example of a community district that is actually similar to most other, or I should say similar to the citywide average. It ranks 24th, so around the middle of the distribution. But I want to take a moment to pause here and highlight what this means to be similar to the average. It means that only half of 3- and 4-year-olds are enrolled in public early education. And this number should be higher. It means that half of children under 5 are in or near poverty. It means that 1 in 5 students need supports through an IEP. So Washington Heights may not be meaningfully different from the average district, but it is very meaningful that the need for robust infrastructure to support families is so common in this district and citywide. The 4th example is Elmhurst Corona, Queens. There are 2 indicators that stand out here, which is the high share of individuals with limited English proficiency. As I mentioned, literacy is an important component of school readiness. And since English is the dominant language of instruction, we should be paying attention to how to support the linguistic needs of families as well. On a positive note, Ecker scores in the district are on average higher than the average community district. However, Elmhurst Corona has one of the lowest rates of enrollment in early education programs. Less than half of 3- and 4-year-olds are enrolled in either private or public programs, so not many are benefiting from this higher quality learning environment. And turning last but not least to the 5th borough, Staten Island, where on the North Shore, the share of students with an IEP is significantly higher than the average community district. Nearly 1 in 3 students have an IEP. This translates to about 7,000 students. No other district has a higher number or share. And so for this community district, the focus is likely to be, and we know that it is, supporting students with an IEP, both why they have one and supporting them once they do. So moving forward, I want to share a few notes, especially for how we might further develop this index. This is, again, our preliminary and first look at these data, and we'll be coming out with a more detailed report after today's event and later this summer. There are a slew of ways that we'd like to further develop this index in the future, including incorporating new indicators that are more directly addressing school readiness, the needs of families with young children, such as access to and progress through the early intervention program. Data about early intervention is still not yet publicly available in a way that can be incorporated into this analysis. But because of persistent advocacy, more data on early intervention is becoming available, and we are looking to doing a deeper dive into that as well. And as always, we're adding new data onto data.cccnewyork.org, including recent city and borough level data on the EI program. I will not discuss all the ideas we have discussed in the past in developing this index, but the slides will be available, and so you can take a look at some of these notes there later today. In addition to that, you can take a look at some of the assets that we have available on data.cccnewyork.org. I think moving forward, we want to incorporate some of this asset data into the index, such as the availability of publicly funded early care and education programs. I want to end with a message. We have enough data for government and philanthropic organizations to act now and invest in community supports for families with young children. However, as a researcher and an advocate, I know that we still need data to drive advocacy and policy change. We need a standardized assessment designed to produce population-based estimates of young child developmental milestones and school readiness so that that can drive community, city, and state level advocacy. And for example, the Healthy and Ready to Learn instrument of the Child Health Survey offers state level estimates, and with appropriate funding could be creating estimates for smaller areas such as counties or even sub-county areas. I'd just like to say thank you to everyone for joining this event today and your interest in CCC's data resources. I'd like to thank the panelists today for the important work that you do that you'll be sharing with us today. And I'd like to thank members of CCC's team, as well as the board members and other partner organizations who reviewed earlier versions of this work and gave critical commentary. Thank you very much.
Thank you so much, Bijan. I think your presentation provides really critical context for the conversation that will follow. And with that framework in place, we are now going to move on to our incredible panel of experts. I'd like to welcome Erasma Barras-Monticchiolo, founder and executive director of Power2, Eileen Gonzalez, early intervention ambassador for United for Brownsville, Beth Mallitz, pediatric psychiatry nurse practitioner at Washington Heights Family Health Center and New York Presbyterian Morgan Stanley Children's Hospital of New York, and Dr. Mary McCord, director of pediatrics at NYC Health and Hospitals at Gotham Health and Sydenham. For a full bio of our guests, please see the chat box. We posted everyone's biographies there. So I'm going to go and dive into our discussion with our panelists. So to start off, something central to all of your work is the importance of engaging families in programs and services for young children. And in Bijan's presentation, he also spoke to the necessity of viewing child well-being in the context of family and community well-being. I'd like to ask you all to expand upon the importance of family engagement in your work, as well as some of the barriers to providing meaningful multi-generational supports. This is also an opportunity to introduce our audience to the work that you do. So Erasma, I'm going to start with you.
Sure, thank you. Thank you, Alice, for inviting me to this conversation, and to Bijan for your incredible presentation, and the entire CCC team for your incredibly long history of advocacy. Our work, as many of you know, at Power2 is relationship-centered and really prioritizes partnering directly with families to decolonize parenting. And what I mean by that is helping parents, Black, Latino, Indigenous people really break free from the dominant colonial European parenting framework that enforced strict discipline and fear as a mechanism of oppression, and that we as Black and Indigenous and Brown people have over the years utilized as part of our child rearing as a way to survive and really protect our children during slavery, during Jim Crow, and how we have attempted to survive the dehumanization of our bodies by law enforcement and other systems, similar to what Bijan was sharing in his data. And our objective really is to partner with families to offer a program that combines an equity-centered, community-driven approach with an intervention called attachment and biobehavioral catch-up that supports families in unlearning maladaptive behaviors and help them heal from that intergenerational trauma caused by our long history of marginalization, right? And so we help parents to develop the confidence in their inherent parenting abilities and develop a sense of belonging and cultural pride as a way to buffer families from racism and to tap into really what comes natural to all of us, right? Which is being responsive, being nurturing, in order to raise healthy, liberated children and really overall strengthen communities. But we know that we sit at the intersection of many systems. And as Bijan mentioned in his presentation, that in order to really help children thrive, we must work across organizations and across city agencies.
Thanks so much, Erasma. Thank you. Those are really important considerations and incredible work that you all are doing. Dr. McCord, I'd like to turn to you now. Can you speak to the importance of and barriers to family engagement in your work? And I think we may have a few slides to go with Dr. McCord's words. Dr. McCord, I think you're muted.
Sorry about that. I want to briefly describe the program that we're working to set up at Health and Hospitals, which aims to take pediatric primary care across the whole system of health and hospitals and refocus it. So it's a 2-generation model. It essentially starts in prenatal care and it aims to get optimal supports in for parents and takes advantage of the role that we think that pediatric primary care plays, because we see, every child goes to the pediatrician, pretty much every child, and they go multiple times, and often the pediatrician is a trusted advisor, or the team at a pediatric practice is a trusted advisor. So if we can figure out how to support parents, we're in a position to do that. So the next slide shows a couple of bullet points about the program. It's risk tiered, and by that I mean actually that that every kid in the practice and every mom who's pregnant is in the program, that we aim to support every family according to the needs that they have. So as a need emerges, then we have people in the practice to help families address the need. And then if it recedes, then they don't need quite as much support. But it's not just a selected group of high-risk people who get the extra support, but everybody, though obviously people that are in an acute crisis would get more intensive support at that time. It's a 2-generation model that starts in prenatal care and really emphasizes that if screening or conversations with parents identify a need and begin to mobilize supports for a family prenatally, there's seamless transition for that into practice and into the pediatric practice. And that in the pediatric practice, we see the parent, particularly the mother, but the parents as in a sense our patients too. Supporting the family is how we support the children. And that in addition, of course, to medical needs, because that's we're a medical practice, that we focus on enhancing the support available for mental health, social determinants of health, and positive parenting support. Next slide. This is just a quick, for those with an interest in primary care, it gives you a sense of where the services are. So prenatal visits, we have the embedded screening for social determinant of health needs, for depression and mental health needs. And then we have integrated behavioral health that is available to moms when they're pregnant. And if after they have babies, we send them back to women's health if they have mental health needs. And we have care coordination, community health workers who help people connect to needs. And then anything that we identify, we work on that handoff and information transfer, both electronically in the EMR, but also personally being transferred over to the PEDS team. And then in PEDS, we have those same services with integrated behavioral health for the dyad. And then we have the specific programs, Healthy Steps, the Video Interaction Project, and Reach Out and Read, which are programs that get at positive parenting from different angles. I want to stop just on the care coordination to say that there's only so much we can do in the practice. So a very key part of the program is, as parents surface needs, connecting them to whatever it is in the community that they may need. So early intervention is a focus. We just partnered with Power2, the mental health services, of course, food insecurity related services, parents who need job training, just whatever the needs are that surface. We can't solve most of that in the practice, but we can connect them to a wide range of community services. Next slide. I'm not going to talk about this actually at great length, but a key thing if we're doing this in a medical practice is that it has to be sustainable. And the way to sustain it is to convince Medicaid that value-based payment, which is the way that Medicaid reimbursement or health insurance reimbursement is being organized these days, needs to focus in young children, not just on treating asthma or their medical needs, but that we have to support primary care to put the community health worker and the Reach Out and Read program and the Healthy Steps program and these programs that support parents, because supporting optimal childhood development is in fact the population health outcome of interest in PEDS primary care. And there might be one more slide. No, that's it. So in terms of the specific question around engaging parents, I think what we see that as being different for every family, I guess is the way to say it. And that we, you know, what we are is a primary care practice. So it starts with that foundation that people come to us to build that relation with their provider. So that's one way that we engage them. But then we have a larger wealth of resources, a different group of people, a team that can get to know parents and support them in ways that the provider may not be. And then from there, we link out to the community, because the community programs like Power2 and early intervention and early Head Start and Nurse Family Partnership and Healthy Families America and the millions of programs that are out there provide yet another level of engagement. So it's really our role, we think, is to figure out what do parents want and need, and then that connect them to that resource, some of which is in the practice and some of which is in the community. So I'll stop there.
Thanks so much, Dr. McCord. And already I think we can hear how folks on this panel themselves are already connecting because of how interrelated all this work is. Beth, I'm going to turn it over to you now to speak about the importance of family engagement in your work.
Sure. Thank you, Alice. Thank you, Bijan, and thank you, CCC, for just always having the hard and good necessary conversations. So I'm here representing our team from New York Presbyterian, and I think what you'll hear is how much collaboration there's been between Dr. McCord's team and our team. We have a lot of similarities in the work that we're doing. So I'll share and maybe try to highlight things that maybe are a little bit distinct. So I think I have a couple slides as well. Okay, so each year, or every 3 years, the hospital is required to do something called the Community Health Needs Assessment. And really what that is trying to gather information from the community itself that we serve on what do they view as their most pressing needs and how can the hospital best allocate our resources to support them. So these were the different components of our 2019 Community Health Needs Assessment. First was identifying our community. So just by pulling from some of our patient data and visit data, we were able to capture the zip codes from which 80% of our patients come. Then using some publicly available data, both at the city and state level and also from our friends here at CCC, we were able to identify what were some of the health and social indicators that we really should be focusing on. We held some focus groups. So again, in partnership with CCC, as well as with the New York Academy of Medicine, we had held a total of 41 focus groups with almost 500 participants that were identified by our community-based organization partners. We also conducted a community health needs questionnaire. So approximately 1,700 surveys were administered across all of our different hospital campuses to, again, gather more data from the community itself. And then lastly, there was the community health think tanks, and those were conducted by internal NYP stakeholders. So again, sort of culling all the data and discussing it, organizing it, and providing feedback to ultimately then develop what we call our community service plan. And that's our response to the needs identified through this assessment. So ultimately, there were 4 priority areas identified. I'm going to focus today on the healthy women, infants, and children priority area. And the specific goals here were to reduce maternal morbidity and mortality, as well as increase primary and preventive care. And I should just say that all of this was aligned with the New York State prevention agenda as well. You can go to the next slide. So as I mentioned, in response to the community health needs assessment, the hospital developed our community service plan, and this was sort of outlining the hospital's measures to improve the health and the well-being of our community. So again, my colleagues and I are focused specifically on the Healthy Women, Infants, and Children programming. So to start, this is sort of an image of where we began back in January of 2020, which feels like a lifetime ago. But what we were able to do was pull together, so myself and one of my colleagues in behavioral health, two of my colleagues in our pediatric division and two of our colleagues in our OBGYN division. And the six of us just began to have conversations to try to understand what programming already existed that we could build upon, what were some of the challenges that our patients might be experiencing when they were trying to come to our clinics and navigating our system. And we really just wanted to try to understand, where were the gaps and where might we be best able to support our community that we weren't already doing. So what we developed initially, again, back in January 2020, was this idea that we had sort of been brewing, which speaks a little bit also to the work Dr. McCord just spoke about. And what we were describing it at that time is enhanced healthy steps. So we were using some core components of the National Healthy Steps model, which for anyone who's not familiar, is embedding early childhood specialists into pediatric primary care to provide social and emotional and developmental support for families. And we had three ways in which we were considering our approach to be somewhat enhanced. The first being that we were going to identify women during the prenatal period in the third trimester and begin providing support to them at that time to help them sort of think and prepare and plan for the birth of their baby, and also to just develop a trusting relationship with someone, knowing that they were about to go through quite a big transition. The second enhancement that we spoke about, or that we thought about, was bringing on an early childhood community health worker. We, as everyone here probably knows and understands well, for our families to be navigating, even within our own system, but then certainly out into our community partners, can be quite challenging. So, we had, with using all of the data in the literature out there to support the use of CHWs, we thought that was going to be an important component to our work. And then lastly, again, back in January 2020, we thought we were quite innovative in thinking about using telehealth. And our idea, again, supported by the literature, was how this might be able to increase access, and just make it easier for women in their third trimester or with young babies to be able to receive the care from our providers at our clinic. You can go to the next slide. So the previous slide is what we sort of envisioned, and then COVID hit in March of 2020, and all of a sudden everything just started to feel very urgent. We had women who were delivering alone at the hospital. We had moms who were COVID positive, who were separated from their babies and unsure if they could breastfeed, and it just really felt like we needed to pull together as many resources and as many programs and people as we possibly could to just start to take care of women and babies. So we had some collaborations and some conversations that had been brewing, but really quickly, back in March, April, and May of 2020, we just started to try to break down all of the different silos within the hospital system and pull back the red tape and just start trying to do our best to take care of families. So we had many phone calls, many Zooms, just trying to pull in as many people as we could, anyone who we thought would be involved in the same similar mission to support women and babies in these very sort of important peripartum days. So what you can see here is kind of where we are right now. This is a map of our current programming, with the women and the baby in the middle, of course, is most important. We want them to sort of be dictating and driving all of the work that we're doing. In that inner circle here, you can see we renamed ourselves from Enhanced Healthy Steps to the Maternal and Child Integrated Mental Health Program. And so the programs in that center circle are sort of the core components of the care we're providing. So again, we have Healthy Steps, which we have some wonderful early childhood psychologists who are working directly with families, both women prenatally as well as dyads once the baby is born. If you hop over to somewhere around 4 o'clock, we have our PrEP program. So PrEP stands for Practical Resources for Effective Postpartum Parenting. And what that is an intervention that was developed by Dr. Catherine Monk and her team. It's this really lovely intervention to help support women prenatally through the 6-week period. Again, just in sort of learning about themselves, becoming a mother, learning to take care of their baby and develop secure attachments and things like that. So we have a really nice partnership with the PrEP team where they've trained our Healthy Step specialists and some of our clinic social workers in the PrEP intervention. So that's now the specific intervention that we're providing to women in that prenatal period. And then we also have And around 7 o'clock, we have our postpartum doula program, and that's a grant-funded program, a partnership between New York Presbyterian and the Northern Manhattan Perinatal Partnership, one of our sort of closest community allies. And that's a program where doulas are there to support women in the postpartum period. They're really wonderful in helping women, for example, make sure they're able to attend their 6-week postpartum visit, get in touch with the provider if they need, and they're really providing a lot of that support for the women directly in that postpartum period. Centering pregnancy is a lovely model. Anyone who's not familiar, I encourage you to just Google it. It's group prenatal care, and it's wonderful, and the outcomes are really remarkable. So sort of in that inner circle, we've developed we have some shared referral pathways whereby if a woman is referred prenatally or a dyad in the postpartum period, we have members of each of the teams working together to try to figure out which is the best program based on geography, based on the needs identified, who has capacity at that time, because our goal really, we know how great the needs of our community is. And we know that the best way that we can even hope to try to meet those needs is by leaning on each other and working together. So we're really trying to come from an equitable perspective and make sure that the women who need the most support get that, but we're also trying to get support to anyone and everyone who would benefit. So we're working again and doing some shared programming and shared referral pathways to balance the issues of capacity and also make sure that everyone, to the best of our ability, is able to get the support that they need. And then in that second tier, we have our New York Presbyterian Hospital partners. So we have a team focused on doing our SDOH screening and then providing resources to families based on the needs. We have a team, it's our neuropsychological testing team that typically works with older children, is now developing a protocol for providing learning assessments for our younger children. I mentioned the Northern Manhattan Perinatal Partnership, which is a huge ally of ours. I would be remiss not to mention our social workers, who are the backbone of everything we do, and they have always been and will always be our closest partners. Through the Center for Community Health Navigation, we have a team of wonderful community health workers, again, who are out in the community working with families in their homes, navigating through what we know are really challenging systems sometimes. We have a partnership with our lactation consultants, and then both women and child mental health services when that's what's indicated for a family. And in the interest of time, I won't go through too many, but our outermost circle, our community network, this is, I think, where we really hope to continue to learn and grow and push further, because as everyone here has mentioned, it's really in the community itself that we know kids and families are going to be able to be most healthy and get that sort of long-term comprehensive support that they need to be their best selves. So those are some of the partnerships that we have developed thus far. And again, we're really hoping to continue to, as Dr. McCord mentioned, find ways that, when the families are in our clinic, how can we best take care of them? But then also, how can we have this village and this safety net around them to ensure that they get what they need?
Thank you, Beth. Yeah, obviously a very expansive program and with a lot of moving parts, as I know sort of all of the work of the panelists is. Eileen, I'm going to go ahead and turn it over to you, see if you can speak a little bit about the work that you're doing and the importance of engaging family in that.
So thank you, Alice, and the rest of the Backbone team at CCC for creating this panel to illuminate the work that we're all doing to support New York City children. Understanding that parenting is a product of culture and is a developmental process is key to how I engage with families. Firstly, I consider how different cultures approach parenting and work to ensure that I don't impose guidance that reflects a white dominant cultural perspective in ways that could alienate families that I work with. Parents, guardians, and caregivers deserve grace over judgment if they sometimes don't have access to information about parenting. So when I engage families, I encourage them to follow their gut, to be aware of their doubts, trust their thoughts, opinions, and concerns. My role as the early intervention ambassador is to support families' priorities and needs to make sure that the families have a support system to build a foundation for early learning experiences. I highlight that I am not associated with an early intervention agency, school, or hospital. My services are free to any family or agency in Brownsville, This allows me to partner with families in an honest and transparent and trusting manner, where I can educate families about the early intervention program to address developmental delays, guiding families to the referral through the early intervention referral process, and reducing stigmas around early intervention. And essentially, more importantly, serving as a liaison between families and service providers in the community. In this kind of work, interpersonal relationships make all the difference in how I engage or choose to engage with families and how they choose to engage with me and the early intervention program. Thank you.
Thanks so much, Eileen. All of this is really incredible work, and I'm so glad that our audience is getting exposed to the work that you're all doing. I think the next piece we wanted to talk about is, something that brings you all together is not just your work with families, but your work with young children. And that's really what brings us together on this panel. Beth, I'm going to start with you again. In talking about the first few years of life and how critical they are, if you could speak to any misconceptions people have about the types of support that young children and their families need, and then I'll open it up for other panelists to have a chance to respond to that as well.
Of course. So I'm not sure that I would call it a misconception, but what I would say is that I think what we really want to do is think about this in sort of a risk stratified tiered approach. Nobody knows better than CCC, all of the sort of universal important work that we have to do around making sure that children have playgrounds to go to and grocery stores with healthy food, and schools that can support their needs. So I think at the base level, we really need to make sure that we're continuing to push and advocate that all families and all children have what they need in order to learn and grow and thrive. And then I guess at the middle level, there's certainly families who, whether it's through Healthy Steps or all of the other wonderful work our panelists and our partners are doing, this concept of positive parenting. There are families who, a very simple approach to a bedtime routine, for example, or discipline or praise, learning how to praise a child meaningfully so that they can, continue to become who they are. I think that mid-level is really, that's where pediatric primary care can really shine, as well as, again, the work out in communities. I think if we can support families they are the ones who are best able to support their own children. I think we all would agree on that. And then at the top tier, those are the families who I think would benefit more from what we think of as like these more clinical interventions. So a focus on early intervention and CPSC and those kinds of things. There are certainly families who would benefit at that level and need sort of that additional support. I want to make one plug for maternal mental health. I think we would be remiss in not making sure that we're keeping a very close eye on that. I think we're doing quite a good job around screening. I think we have a little ways to go around supporting moms so that, again, they can best take care of their babies. So I think we have to, in parallel, really focus on those universal interventions as well as, the top tiers. But, I think what would be so lovely is if one day we were a little less focused on EI and, things like kids playing and having fun at the playground is what was helping them be ready for school. So I think it's that tension and in both areas that we want to focus.
Thanks, Beth. And sort of following up on that, Eileen, I want to turn it back to you because I know you and I have spoken both about some of the misconceptions, but also some of the stigma associated with services for young children. So I want to see if you have any response to issues around issues that your misconceptions you might be combating when you're serving families, or some of the challenges in making sure you're able to get those supports to young children and their families.
Sure. Thank you, Alice. The most common misconceptions that I see in my work surround issues about whether families are responsible for paying for services in the early intervention program. They're concerned about maybe they need a referral from a pediatrician per se, or that they need insurances or immigration status play a part. So these are some of the 4 key themes that I see, or that families have never heard of the early intervention program and don't have enough information to really gauge their interest in the program like so. So taking into consideration some of the roadblocks that parents might face, in addition to deciding or not whether to apply for the early intervention program, could either set the child apart from receiving services from a month from today, 3 months from today, and all of this sort of plays a part and is how I approach our families to make sure that I clear out all sort of the misconceptions first before we start engaging in some of the referral processes.
Thanks, Eileen. And I think that's so important because for all the work we're talking about, we have this window of young child development and we want to get those services as early as possible. So those months are really meaningful at this age.
Absolutely.
Yeah. Erasma, I'm going to turn it over to you for the same question.
Sure. Yeah. I just wanted to add that, we've recognized that the first 1,000 days, right, are basically the brain's window of opportunity. And it's a really critical time that shapes the architecture of a child's brain for life, with billions of neural connections that are formed, every minute. And so this window of opportunity is also the greatest window of vulnerability, right? So we know firsthand that the toxic stressors faced in the communities we partner with, right, that were outlined in Bijan's presentation, have an impact on a family's ability to thrive. And so one of the many misconceptions that we face, and which our work really tries to address, is that families only need the basic essentials, right? We hear that very often. It's just like, no, they actually need more than that. They need support in parenting. They need to be able to heal from intergenerational trauma. They need access to additional services. And another misconception that we hear is that early childhood is too expensive, and that it's too expensive, and that we can't commit to investment, when we have ample evidence actually to show that investing in early childhood really delivers dividends very later on in life, right? So studies on successful interventions put the savings anywhere between, $4 to $9 of return per every single dollar invested in early childhood programming. And so for us, right, what we think about is that in order for children and families to really thrive, we must do a combination of things. We must, as Beth mentioned, focus on, the early years. So those first 1,000 days, we must also look at that continuum and support them as they, transition into toddlerhood, and then start, early education programming, right? And also simultaneously really addressing, the systems of oppression and racial injustices which influence all the indicators that Bijan was talking about earlier.
Thank you so much. That's such important points around sort of all the intersecting pieces that are impacting young children at this time, and the importance of those early years. Dr. Morgan, I want to turn it over to you if you have anything you want to add on this particular piece around sort of the importance of young childhood and any misconceptions that you may have encountered. I think you're muted.
Sorry again. So I think the other speakers were on point in pointing out the key things. I would just add, and this is a little bit from the point of view of a pediatric practice, but that every family's trying to be the best parents that they can be for their children. I think you pretty much never see exceptions to that. People from all kinds of difficult traumatic backgrounds arise to the occasion in terms of what they're trying to do. And the support that every family needs is a little bit different. So that the challenges that we have are to identify the need of that particular family. I mean, maybe a mom's depressed and the depression needs to be addressed. Or maybe a mom scores positive on a screen for depression, but what she really needs is help paying the rent. Or maybe the problem is that a mom who says, yeah, everything's fine, but that they're struggling in ways they're not telling you related to current traumas or past traumas, trying to be a different parent than the parenting that they had. So I think you need to provide the supportive environments that you can through Healthy Steps or Video Interaction Project or those types of things. And then you need to have multifaceted attempts to listen to people. And I think screening is important. If we don't screen, people are gonna fall through the cracks. But I don't think screening is the main thing in a pediatric practice. I think what I see is the clinical conversations. So the conversations between, like Eileen said, the interpersonal relationships, that we need to bring out the it needs to be both of those things. So and the bottom line is we need mechanisms that family needs can be expressed, whether the family's ready to tell you this is what I need, and a lot of families are, or whether there's barriers to that and we need to kind of be gentle in our approach and to allow the needs to emerge, rather than saying, this is our program for early childhood, we do this for every family.
Thank you for that. And Dr. McCord, I'm actually going to stick with you because you've already raised some of the issues for our next question. And you also raised this in sort of your introductory remarks, but so much of beyond just screening for needs, as you said, is not the be all or end all, but the big component of this is connecting children and families to the community-based services they need, like WIC and early intervention and home visiting. And I wonder if you could speak in a little more detail to the importance of addressing those social determinants of health and discuss what are some effective strategies for strengthening community connections.
So this is an important point. So I think that the screening is one that you need to ask people what they need, or maybe another angle on it is you need to tell people these are the services. This is the array of services that we have the ability to connect you to. We can text you to help with your taxes. We can connect you to help paying rent. We can connect you to legal advice around immigration. We can connect you to support if interpersonal violence is an issue. We can connect you to parenting support. So it's something universal. There has to be something that universally goes to everybody in terms of asking about needs. But then once you need services, you need to have an ability to connect people to services that are decent quality. And the number one mechanism for that is partnerships. So building partnerships with smaller organizations that are in your community is really key, because then you know what they can do. And also you can connect somebody. You can say, go to this agency and talk to Jorge because he's the one who helps with that type of problem. And you only know that because you have a partnership relationship. But you can't only work with partnerships because maybe your family doesn't live in this neighborhood and they live in some place that's a few miles away in another borough. So I think you also need to work with agencies like early intervention, kind of the partner with the citywide programs. And then I love programs like Power2 that somehow manage to give that personal connection with a 5-borough-wide program, because we can connect to them. We're just building our partnership with Power2, but we can connect to them in a way that feels like we are learning to understand each other and know the strengths and weaknesses and how we can work together. But I don't have to worry about what's the catch, where the zip code of my patient, because they're going to figure out a way to solve that problem on their end.
Thanks for that, Dr. McCord. So I'll actually turn to Erasma because coming from the other side of Power2 and sort of how you're able to get tapped into some of these other networks who are really seeking the kinds of services you offer.
Yeah, no, Dr. McCord, hype me up. I'm so excited about our partnership and all the things that we're going to accomplish together. But she's speaking the truth, right? That it's really important for organizations to partner not only with each other but also as part of an interagency movement as well. And as a in-home service provider, we are able to really establish these trusting and lasting relationships with the families that we partner with. And as a trusted partner, we know firsthand the intersectional toxic stressors associated with the social determinants of health that families regularly contend with, right? Such as the one, Dr. McCord mentioned: housing instability, food insecurity, lack of access to quality and culturally competent, whether it's healthcare, mental health services, employment opportunities, and, oftentimes equitable education. And so, one of the things that we have done as part of building those relationships with families directly is to listen, as Dr. McCord said, is to really listen and hear what the families need in addition to, the support that we're giving on the parenting front, right? And so because we listened, we were able to create what we call a resource specialist, an in-house resource specialist role within our organization that actively assesses the family's need and connects families to vetted community resources, right? But the challenges, of course, that we experience is that these trusted partners sometimes have limited capacity, or as Dr. McCord mentioned, are located outside, outside of the community. So it makes accessing them challenging. And so, others right now are limited because of COVID and the pandemic, right? And, agencies themselves were caught flat-footed as a result of the pandemic. And so trying to create a system that is integrated, that is listening, really actively listening to the needs of the community is absolutely critical.
So Rasma, and I, continuing from that, I want to turn it to you, Aileen, and I apologize, I was mispronouncing your name earlier, Aileen. But you're an ambassador. Your goal is very much in reaching out to communities and connecting them. And so I hope you could maybe talk a little bit more about how that, what some of those opportunities are and challenges in terms of that real community connection to different resources.
Absolutely, thank you. And I love the way Erasmus put it, interagency movement. And that's what the ambassador is responsible for doing, is really getting a buy-in from social service providers and families that early intervention matters. The first 3 years of life matters, and giving babies priorities and understanding their competencies and abilities. And it's really approaching the agencies like, hey, asking the question is like, how do you engage with the early intervention system? Or when was the last time you ever referred to the early intervention system? And helping agencies sort of self-reflect on their abilities, or helping them sort of find the pinpoint person, a key person to refer to early intervention or to talk to a family about early intervention. And my goal is to make my role as sustainable as possible and our impact to the social service agencies. So that's either me imposing all of my knowledge about EI onto you and to your key person, or talking to your entire staff at your agencies. Most agencies have been super responsive, want to work with early intervention and understand the values, but they have a hard time engaging families or finding families to stay committed to a program like early intervention. And data shows that families move in and out of Brownsville. So part of my ambassador role is to follow families across New York City. Hey, you're living in the Bronx? Don't worry, the systems are so similar. I could support you in that borough. You're in Queens, the same thing applies. So really sort of having names and context of families, no matter where they are in the city, that's the network that I need to be successful in my role. And giving my resource that's free to Brownsville, Brooklyn, or Central Brooklyn, to daycare centers who oftentimes don't have this resource or didn't know something like this existed, and then approaching bigger schools like Head Starts and public schools who have young children going in and out of the building doors. And that's the important work of networking, of being sustainable, and again, back to this interagency movement that it's so helpful in the work that I do.
Thanks, Aileen. And then now I want to turn it to Beth, because I know, in your slide presentation, you had sort of the rings of different services, both sort of on site, but also so much of that is obviously about having those connections to other sources in the community. So I wonder if you could answer this question as well about strengthening community connections.
Sure. I mean, obviously they all nailed it. But I guess the one piece I would add is this phenomenon that perhaps some of you have come across as well, that, in our effort to help, sometimes we are just absolutely bombarding families with quote unquote resources and support. So I think part of the work that we're doing, like I said, and having these shared referral pathways and these really close connections and calling up Jorge, is to be able to, again, listen to the family. What is their priority goal right now? Not what's our goal for them, but what is most important? What's the number one way that we can support them right now? And then rather than 17 different people calling them to say, hey, I'm the one to help, really honing in on who is that one right person to make that phone call, who is the one right person to get them from point A to point B, so that we're all, again, just really following what are their goals for themselves as a family, not what do we as providers want to impose on them.
Thanks so much, Beth. Yeah, I think that is a through line through, I think, what everyone has been saying is the importance of really centering the family, their specific needs, their desires. So with that, I want to move on to the next sort of question I want to pose to everyone. And I'm going to start with you, Aileen. We know that early intervention has for decades had inadequate provider capacity, but we know from a lot of the data out there, as well as the experiences of families, that children in low-income communities of color are significantly less likely to receive EI referrals, evaluations, and services. And a lot of your work is really around reversing those trends. So I hope you can talk about strategies that you're using to support engage Black and Brown families in accessing services and supports.
Sure. So early intervention, like other health and education systems operating in Brownsville in specific, must be understood in the context of structural racism and public disinvestment, both historically and currently. So one result of this context is a widespread sense of suspicion people and residents in Brownsville have towards the systems they're told are here to support them. So therefore, my fundamental strategy is to build trust with parents and service providers. And in order to do this, first and foremost, I try to demonstrate a sense of empathy with parents and caregivers, listening without judgment, validating the experiences they share with me. And the second tactic is to be strength-based and family-centered in my approach, where I highlight what the family has done, what they're currently doing, that seems to be working well or not. And I try to sort of take an open door approach so that families feel that they could be connected to me at any time and find a helpful source of support. Whether early intervention is the right program for them or not, I'm still there to consult and coach the families about parenting and their early childhood learning experiences. And using these approaches, I support families who may be in denial, on the fence, or have accepted their child's diagnoses. I advise families towards what their child needs right now and what services are appropriate for them. I encourage families to create lots of happy memories together, acknowledging all the character traits of being human, and showing real, deep, authentic care encourages parents to participate and engage with the early intervention program. So families in specific Brownsville, in particular, want to work with providers who look and speak like them and show genuine interest in their young child. And that's a trend I'm observing with all the families that I'm working with. When I am working with a family who, again, may be on the fence about early intervention, I am careful not to judge the family and their beliefs. I take into account the community history and have vetted early intervention agencies who have reputable standing in Brownsville and have a good track record for providing services there. I am mindful of the stigmas and concerns that parents have, which are legitimately rooted in experiences that they, their families, or their communities have had, or that stem from having enough or accurate information, right? It may also be rooted in difficulties in the referral process itself, which is often complicated, or suspicions about the special education program and their child being labeled. All of these opportunities or approaches that I have really rely on the element of trust and genuine care for the well-being of Brownsville children and Central Brooklyn.
Thank you so much, Aileen. Sort of, again, following up from that, Arazma, I know you spoke in your introductory comments about, the impact of systemic racism that's impacting every single system that we're looking at. I wonder if you want to speak as well to sort of some of the issues you're seeing and how you're trying to combat and reach communities of color and families of color.
Sure. I mean, at our core, Power2 is a racial justice organization, and we don't shy away from the true history of how our nation was built. We acknowledge the impact really that post-traumatic slave syndrome and existing racist systems and policies has on our Black and Brown and Indigenous communities. And so the racial equity dimension of our approach stems from our team's collective lived experience, our deep networks within New York City communities of color, and our commitment to really co-creating initiatives that share power, right? And are supporting communities to develop methods of self-advocacy to disrupt these oppressive systems. And so we are maximizing the positive effects of, the responsive parenting work that we do to address trauma and support stronger relationships between, parents and children. And this really sets the strong foundation from which we can engage the wider community in really true restorative practice. And that is one of the most, fundamental ways in which we grapple with the historic and the systemic racial and economic barriers to access. But our work has also given rise to, a community ambassador program, which really fosters racial consciousness as the framework for advocacy and creates opportunities for community members to reclaim and exercise their power and agency, both through, training and connections to opportunities for self-advocacy and, for self-advocacy, but also for their community as a whole. And so by partnering with families in all of these different ways, we are identifying and co-creating hyper-local solutions that address the current and historical issues that limit the healthy development of children and families and communities as a whole.
Thanks so much, Erasma. Great work around all of this, and thank you so much for sharing the ways you're sort of approaching this, and how not just how you're approaching it, how central this is to the work that you're doing. And I'm going to turn it over to Dr. McCord, if you could speak a little bit about how health in hospitals, and specifically within the work that you're doing, is confronting a lot of the structural racism that we know is creating such long-standing barriers to care.
First, I just want to call out something that I think Beth said to emphasize the problem of too many care coordinators. That I think there is an emerging problem with all the attention that there is on early childhood, that families are getting bombarded, and particularly with the risk tiered approach. So we have sometimes a high risk baby. A baby will be born to a mom whose high risk was recognized in pregnancy, and there'll be like 4 people tripping over each other to get into the room, and we know it isn't going to help the family. So we have to get our act together around the multi-service program thing, but that's an aside. I think health in hospitals, the structural racism is a real problem in healthcare, because healthcare kind of embodies centuries of structural racism within its structures, and so it's a challenge to be, in a way, to work. But I think across healthcare, not just at health and hospitals, people are recognizing that and beginning to talk about just the fact that it's true, that racism at all levels is there. Health and hospitals is a complicated institution, though, because it's much more representative of the communities. You wouldn't know that looking at me, but much more representative of the communities that it serves historically. That it's we look like you has been a health and hospitals logo, and they really do value that. So I think that's one thing, is kind of elevating that history or tradition within health and hospitals. But the other key thing is is the team. So for us, integrating the community health worker, and then now we're talking about doulas also into our team, where that person is explicitly not drawn from the kind of traditional structure of healthcare, and it is there to challenge us a little bit, and to elevate the patient's voice within the system, and to help the families speak their needs to us. I think that's one thing that we're trying to do, and then partnership is the other thing. So you can tell I'm a fan of our recent Power2 partnership, but the partnering with Power2 and with local community agencies. We're trying to figure this out with early intervention on a citywide scale, recognizing that we don't have all of the solutions, and that sometimes we don't even understand the questions, and we need our partners to get us there. I think that's probably, for healthcare institutions, what we need most to do is to begin to get that humility to say, honestly, we probably have been doing this wrong and don't know exactly what to do. How can we figure that out? And without throwing the baby out with the bathwater. People value our expertise on a certain level, so we need to still be there for people with the skill sets that we do offer, and recognize the blinders that we have on to try and get better at what we do.
Thank you, Dr. McCord. And Beth, I'm going to turn it over to you too. I know obviously New York Presbyterian grappling with a lot of these same issues of really sort of longstanding challenges in terms of equity and sort of countering some of these deep-seated structures. So I don't know if you have additional comments you want to make there.
Sure. So like Erasma mentioned, I think we can't shy away from these conversations. I need to enter every single time I'm working with a family and put it on the table. What has your experience of racism been in our system? What has your experience of racism been in working with me? Let's talk about it and let's work through that. We have this concept in behavioral health that I come back to all the time, So the idea is, I try to come, and I think we all try to come to families by saying, you're doing the very best you can with the resources that you have up until this time. What more can I offer you so that you can do even better? Because I can't do it for you. I shouldn't do it for you. You are clearly the best person. You're clearly the right community to take care of these children. So how can I help empower you, use the strengths that you already have so that you can continue to, just learn and grow and thrive, and your children can as well.
Thanks, Beth. So I think that, as we're sort of looking at the timing, I want to make sure we get to a couple of more questions before we close out. Erasma, I think the next question that I'll start with you, but we want to pose to everyone is, obviously, all of the issues we're talking about have been deep-seated. These are challenges that face New York City children and families forever, whether it is structural racism or whether it's lack of adequate access to young child services, all of these issues. But we know then COVID-19 hit, and that had an even greater impact on what was already there. So I wonder if you could talk a little bit about what the impact of the pandemic has been on the children and families you serve, as well as sort of the way you deliver services.
Sure. As we know, the pandemic disproportionately affected Black and Brown and Indigenous communities across the country, across the world, and obviously here in New York City, it laid bare the economic and racial disparities that are and have always been present for our communities and for the families that we partner with. The pandemic detrimentally affected almost every aspect of their daily lives. The disruption to the economic safety nets on which many rely created additional stressors that, coupled with fear, social isolation, lack of adequate health and mental health services, lack of access to the technological infrastructure needed to navigate teleworking or at-home schooling, in addition to the fear of illness or death and how to keep themselves and their families safe, was in many ways devastating. But what we saw is that once again, our families showed the incredible strength and resilience that really characterizes our Black and Brown and Indigenous history in so many ways. So as the pandemic and its immense disruption to daily life began and became very clear to us at Power2, we pivoted to a teleservice model that allowed our families to continue to engage with our program. And we also became a source for connecting families to the essentials that they needed for the pandemic, right? So including PPE equipment, and to meet many of their needs of technology, food, essentials for their children, including diapers and clothing. In terms of, when thinking about additional steps that providers and city and state agencies should, let me correct myself here, not say should, but must take. Chief among those would be to really prioritize the needs of the most marginalized communities, right? So despite being, the labor force that kept the economic engine of this country running in 2020, our communities were also the hardest hit. They were the ones that received the least amount of help, and they were also the ones that, despite the huge numbers of infections, were not prioritized for vaccine distribution. And so our government and the policies that they enact or fail to enact continue to place, our most marginalized, our most vulnerable at risk. And so it is systemic. It is born out of our nation's racist beginnings and the systems of oppression that continue to uplift those systems to benefit some at the expense of others. We really must end that. And we need to do that as a collective.
Thank you, Erasma. Thank you so much for those remarks. And continuing from that, Aileen, sorry, I'm going to turn it to you because I know that, I know CCC, we've certainly been watching the data on early intervention and some of the, steep declines that we've seen in access to those services. So I wonder if you could also speak to sort of what impact you've seen in communities that you're serving, as well as the specific services they're receiving.
Sure. In the current work that we're doing, I've observed sort of increased levels of distrust as families experience sort of the shortcomings and the failings of the support systems during the pandemic. And specific to the early intervention program or programs that provide a service, it was hard for providers to transition to teletherapy, to continue visiting the homes of young children. So it was hard to meet children where they were. Essentially, we're going to the schools, the homes, and that changed at the height of the pandemic, and is still in effect today. So the difficulties are, I mean, most programs have been adjusting to the new norms, so to speak, but for sure, I think at a state and local level, there needs to be sort of a movement of local hiring so that providers look like the children that they're working with, and really pulling from the resources in the community and looking at the special education support teams in public school systems that may be interested in working with young children.
Thanks, Aileen. I'm going to turn it now to Beth and then Dr. McCord. And for both of you, I know that, you know, when we're looking at data on the impact of COVID on the mental health of young people, that data, first it's sparse, but what we do have tends to be for adolescents. It tends to not be as much for young children, but we know that COVID has its own unique impact on young children and their parents and their caregivers. So I wonder if you could speak to sort of what you're seeing in your practice on the impact of the pandemic.
Sure. I mean,
start with you, Beth. Sorry.
Okay, sure. You know, I go back again to last spring, and you know, a woman delivering alone in a hospital without the support of a partner, not knowing whether she was going to transmit COVID to her baby, not knowing what that would mean if in fact she did. I mean, I don't think we can sort of understate the terror, the fear, the trauma that they've experienced. You know, in this 2-generational approach, which I think we all recognize is, you know, the way forward. You know, I'm really continuing to hear from moms how devastating it was to feel like they couldn't take care of their children. So I think that's a theme that we're continuing to really hone in on and focus on, trying to just, again, from a trauma-informed approach, listen and understand what happened, what was that like for you? And then, you know, from more of an empowerment angle, trying to help moms realize that they did in fact take care of their children the very best that they could. And now, you know, little by little, you know, how and when they feel safe, they can start to begin to rely on us again.
Thank you, Beth. Dr. McCord, do you have anything you want to add?
I think I would just highlight that the children with special needs didn't get any services, and that needs to be, I think, explicitly addressed. And as you all did, that Black and brown families and poor families in general by far took the brunt of this, and that the recovery needs to put resources where the trauma was, I think. And yeah, and then to mention that, you know, I think the older kids took more of a direct, it was an indirect hit to the younger kids, unless they had special needs. That around, it depends on how difficult it was for their parents. How, and if, you know, if their parents had lost their jobs in ways that are long-term stressful or became depressed, or that's a problem. But I think that the adolescent and school-age kids are lost, and that we need to be really, and that's affecting families, and that we really need to be figuring out what it means to come for them to come back into the world. And it's not I'm not worried about what they lost educationally. It's more in terms of their psychosocial development. And, you know, maybe it's going to be okay when everybody goes back to school, but that's not what families are saying. Mm-hmm. I have a lot of kids that are saying, I don't want to go back to school. And, you know, because it wasn't so great before, I think it's going to be really complicated, and that we really need to be putting resources into supporting schools and families in the communities that were hardest hit, and kids with special needs.
Thanks, Dr. McCord. So I think that, you know, I think one of the final questions that we wanted to ask is around, you know, you're all doing incredible work with young children, with their families, but we know one of the biggest challenges is, of course, sustainable funding for these services. So for the final question, I want to give you an opportunity to speak to what you think city and state leaders should be doing to increase access to the programs that you provide and those that you rely on. And also, if there's anything else that you want to add as sort of final words as we're nearing the final part of this panel, feel free to put that in. So Dr. McCord, I'll stick with you for now.
Well, I'll be brief. I think that in general that we need to invest in the communities that were hardest hit by the pandemic, because they've always been hardest hit by everything. And I think that investing in early childhood resources, so childcare, parent support of all different types within the community agencies is critical. Specifically on what I do, which is primary care, pediatric primary care, I think that those of us who are in that world, the advanced model of pediatric primary care that was part of the first 1,000 days initiative, it needs to be supported through value-based payment or it will die. So we need to come together around a value-based, and this is getting into the weeds, only in case there's other people out there that are this. The 1115 waiver is beginning to talk about. We need to be vocal about the importance of early childhood and prenatal supports built into these practices being seen as a core fundamental service. I'm happy to talk more to anyone who's interested in what that means.
Okay. Thank you. Beth, I'll turn it over to you.
I couldn't agree more. I think we just have to, normalize this as the standard of care. All of what we're describing is, work that is new and these partnerships. But I think we will come to realize how valuable it is, and that this just, I hope sometime soon can just become how we take care of women and babies. And the other thing I just want to say is it's been an honor. So thank you for having me. And I really appreciate all of the panelists, and again, feel honored just to be among you all.
Thank you, Beth. Aileen, I'll turn it over to you. Same question about sort of what, what you think city and state leaders should be doing to help strengthen the supports that we're currently seeing, and any other sort of final remarks you might have.
Sure, thank you. So the role like that of the early intervention ambassador is a pilot one. So we're hoping and working really closely with the Bureau of Early Intervention and other stakeholders to try to scale up this early intervention ambassador role and bring this sort of racial equity work in early intervention into other neighborhoods, other surrounding neighborhoods. And without funding, this is just an idea. The early intervention ambassador taps into the community, which makes them or myself a trusted messenger and helps families sort of participate in an equitable system. And essentially United for Brownsville, myself, we're looking for a tangible benefit that improves the lives of Black, Latinx, Indigenous, and Asian people. And I think that we should throw our political weight behind policymakers that and policies that universalize sort of the essentials of life, like education, like health, like early intervention. And we have to target our resources to create equity between groups and practices and policies in communities like Brownsville. So again, thank you, Alice, for having me. And a pleasure meeting everyone on the panel.
Of course, thank you so much. And Erasma, I'll pass it over to you.
Sure, thank you. So, the long-term effects of the increased trauma from the pandemic is not yet known. But those of us that are partnering directly with families know that it has the potential to be significant, particularly for historically marginalized communities. And so while I am incredibly heartened by the Biden administration's commitment to invest in supports for children and families, policymakers at the city and state level must also make that same commitment. They must collaborate directly with community, listen to our recommendations for funding of vital services and programs that really uplift families. We need committed and vocal leaders who will fight for our communities, not just during elections, but also when budgets are drafted and funds are allocated. So if you're listening, this is the time to invest. They must not just aim to fund the services and programs that helps families survive systemic racism and oppression. They must also take on the systems themselves through the policies that they enact to really fund organizations who are actively doing the work to support families across the board.
Thank you so much. Thank you so much to all of our panelists. This has been a really incredibly important conversation. I know it will continue among everyone on this, as well as among yourselves as well. So, I want to let the folks in the audience know that we will be following up with a recording of this panel. We'll also be following up with the presentations that were included if you want to see additional detail and contact information, so you can reach out. But I can't thank our panelists enough for the incredible work they're doing. And thank you also, Bijan, for your presentation at the beginning of this. And with that, I think we will close out, but feel free to reach out afterwards. And thank you to all of you on both the panel and listening for all the work that you do for children and families.